Good evening, sir.
ನಿನ್ನೆ ನೋಡಿದ್ರಲ್ಲ ಓ ಅದೇ ನೆನೆಸಿ ಓದೋದು.
Hey guys,
So we'll start in next 5 minutes.
you want me to share so that I can check whether the things are working.
Okay, sir. Evangeline, please share the screen button for sir.
Yeah, I've done that. I have allowed screen sharing.
So you can share your screen.
See?
Yes, sir, your screen is visible.
Full and see whether you're able to see.
Yes, sir, it's full slide, sir.
Moved?
Yes, sir, the slides are moving well.
It's 2031. When you say yes, I'll start.
Okay, sir.
I think we can go ahead, no, sir?
Okay.
Go ahead and start now.
I'll start the introduction, then we can start with the session. Good evening, everyone. I'm Dr. Alish, a final year MCH resident at SAIN Mumbai. Hereby welcome you all for this IAPS NextGen lecture series. The idea of which came up by to discuss all those difficult topics that we face as residents in a form of lecture series. Today's session we have on pediatric urodynamics, commonly known as UDS study. And to discuss this, we have our respected Dr. Ramesh Babu, sir. He is currently working as a professor and chair, senior consultant in pediatric urology at Sri Ramchandra Institute of Higher Education and Research, Chennai. He was the past president of IAPS. He was a past chairman of Pediatric Urology Society. He has many laudets under his name. He has many chapters written. He has many publications under his name. We feel completely honored to welcome you, sir. I and my colleague Evangeline welcome you for this session. Over to you, sir.
Just before you start, sir, I'd just like to request all the participants to mute yourself so that we can all hear the speaker clearly. Yes.
Let me start. The scope of this talk is to discuss about various types of bladder as well as outlet assessment. It can be in the form of a simple bladder diary, uroflowmetry, non-invasive urodynamics, home monitoring, Uroflow, conventional urodynamics, ambulatory urodynamics. I will see whether I can cover a little bit of theory, then practical, and then also we'll try to have some scenarios, and then we'll have some questions. So the home monitoring of bladder volume and the PVR is a very popular method abroad. For example, I had a child recently from the United States. The child had undergone, the patient has undergone a spina bifida, myelomeningocele repair there. They have just been given a ultrasound machine, home ultrasound machine, to look at the bladder volumes, particularly the PVR in a newborn baby. So they've been watching it, shorting it down, and then that is the simplest thing which they were doing to look at the PVR and then measure the volumes. So this is a very simple method which they are following in neurogenic bladder patients by giving a home ultrasound machine. We have a lot of non-invasive voiding phase studies. So the voiding phase can be easily assessed by uroflowmetry. So you do not need a full-fledged urodynamic setup. if you want to diagnose only a voiding dysfunction. So you need to think before you ask for a urodynamic study if you are treating a child with a voiding dysfunction. So that can be added with the Uroflow electromyogram. Also, you can add an electromyography to this. But a simple voiding phase study, a Uroflow, can be a bedside test. It can be available in the outpatients or in the washroom next to the outpatients. And this can be very useful test in several conditions where only voiding is a problem. Ambulatory urodynamics is a completely different ball game. Here you have an indwelling bladder pressure monitor. It can be inserted via a suprapubic puncture also. We'll come to that later. Then the conventional urodynamic, what we call as UDS, is a filling phase study or a cystometry. So cystometrogram is basically to look at the pressures of the detrusor. In addition, what happens to the sphincter also. So you can assess all that. Then comes the video urodynamics, where you have added a contrast also to the solution you're using. So you can see much more information about what is happening to the contrast in the bladder. Then provocative urodynamics is basically you occlude the bladder neck with either a balloon or you put a ureteric catheters to stop the reflux, ureteric balloon catheters, and then you mask various fallacies of the conventional urodynamics. Then you have a biofeedback. So we'll come to all of that over the course of this lecture. Now, voiding diary is the simplest thing which you can have in the assessment of the children. So a typical voiding diary is it measures the timing, the volume. It may also add the fluid intake and then leakage episodes, all that. Now, the normal voiding in any child is like what I say is before school they go twice, during school they go twice, and in the evening 3 times. So normal void is around 7 times in a normal child. So let us see this 9-year-old child. The weight is 30 kilos, and the expected bladder capacity is by the formula age plus 1 times 30. You can even use age plus 2 times 30 also. Both are the accepted formulas these days. So it's around 300 ml. But the urine output is a 24-hour output is depending upon the weight. So if the weight is roughly 30 kilos, you have a 720 ml of urine. So although the bladder capacity is 300 ml, we never hold the bladder to the full capacity. So what happens is around 1/3 or 1/2 the capacity, the child voids. So the total expected output of 720 ml, the child probably will void like 100 ml every time. And then the early morning void is usually more than the rest of the voids. So this is how you would expect a normal child voiding to be. So the number of voids is what is the usual important thing to look at. What is the frequency? But in a classical child, you do not have exactly like this 100 ml divided by 700 ml divided by 7 times. So there may be 180, there may be 150, and then there may be in the evening they tend to go more often because they have access to the toilet. So in school they probably hold it for a longer time. So this is what typically happens. In a child with urgency and frequency, probably the same thing is going to be multiple times of voiding, which is like 40 to 50 ml, and then multiple episodes of voiding. So you probably will have around 15, 20. Then that is a smaller volumes, increased frequency. Okay. So the maximal voided volume can be expressed as a percentage of the expected bladder capacity. So there are formulas saying that if it is less than 65%, it is low, and if it is more than 150, it is high. That means that if the bladder capacity is 300 and the child is holding up to 400, that is not correct. So something like that. Now, ICCS definitions are something which you need to know. Frequency refers to more than 8 voids per day, and a decreased frequency is less than 3 voids. Nocturia means waking up at the night to void, and waking up the night is not abnormal. Maybe they are just having an increased production of the urine in the night. Normally, when we have a normal output of 1 liter as an adult, we don't tend to produce equal amounts. We tend to produce more during the day, but the entire night we probably produce only 300 ml and not half of it, like 500 ml, because we can't hold 500 ml. That's because the natural antidiuretic hormone. If the antidiuretic hormone doesn't work as well, or if it hasn't developed in a child, the child can wake up in the night to void, or in a patient with the diabetes or various problems. So nocturnal polyuria means nighttime increased capacity, increased output. So more than 130 ml of bladder capacity. So, and that is what you work on. So nocturnal polyuria also may be more than 20% of the total output that is happening in the night. Though there are multiple definitions for nocturnal polyuria. Let us not go into the details of that. Let us come back to the basic test. So uroflowmetry, as I said, is a non-invasive method. It's very simple, but it is useful only in a older cooperative child. You need a child who is like 4.5 to 5 years age, who can obey your command to void and hold until the bladder is full. So in all children, it is not possible to get a uroflowmetry, but the older they become, it becomes much easier. So the bell-shaped curve is usually the normal curve. It can give a curve patterns and flow rates, and you can also have a Uroflow nomograms. So these are all different types of bell-shaped curves. So it can be like this or like this also. This is another Uroflow bell-shaped curve. But only thing is, we will come to this later. This is a Uroflow nomogram. Nomogram is a Sirocchi nomogram. It can be age related or volume related. So this is a volume related nomogram. And then for that voided volume, what is the Uroflow? So that is what it is looking at. If the child is holding it too long, like for example, at 300 ml instead of they are passing 400 ml, then obviously the Uroflow will be abnormal. The nomogram will still be normal. So what are bells? Normal bell-shaped curve can be multiple things to multiple people. So we need to know a little bit about it. A bell-shaped curve does not always mean normal. So you don't actually look at the peaks, you have to average it out. So what I mean is, for example, if you look at it's a bit like an ECG reading. So if you look at the printed material, you will have a maximal flow rate as 21 here, but that is just a single peak. So you have to average it out and then get the peak yourself, because that is probably a small cough or some artifact there. So the Qmax in this patient is 17. And when you write a Uroflow report, you always write 3 numbers: Qmax, voided volume, and post-void residue. So they always are supposed to have a small ultrasound machine where you can measure the post-void residual volume. So in this patient, this is how it is written: 17, 180, and 20. So 20 is the post-void residual, and usually it is less than 10%. So there are a lot of components of it, of a Uroflow curve. So one is the time, the other one is the flow rate. So the flow rate is in ml per second. So what you get here is the maximum flow. That is the Qmax. Whereas an average of all that is the voided volume by the flow time. So the voided volume is the total volume from here to here, and the flow time is also there. So the volume to is average flow rate. So average flow rate is somewhere here. It is not here. Now the time to maximal flow is TQ max. Then this is the flow time. So we have all these details. When you read Uroflow, the most important thing is Qmax, but the Q average is also important. Qmax is usually the square of Qmax should be more than total voided volume. So for example, if it is 10, then 100, then that is more than 100. It should be more than that. Uroflow index is an index where the Q average is expressed as a fraction of the Qmax. Now, if you look at the classical bell-shaped curve, if I say that the Qmax or the flow rate is around 10 and Qav is 5, then the Uroflow index is 0.5 because it is 5 by 10, Qav by Qmax. So that is a pretty much a normal Uroflow index. Now, when you have a Qmax of 30 and a Qav of 5, then that becomes like 5 by 30. So it becomes 1 by 6. So that is an index which is probably suggestive of a high pressure voiding, which is a feature of an overactive blood. The reverse is also true. For example, you have a Q average of 4 and Q max of also 6, then you probably are looking at some kind of obstructive uropathy there. When you combine a post-void residual with the Uroflow, it becomes a very good tool to exclude obstructive uropathy, particularly when you have this meatal stenosis after a circumcision or after hypospadias, or in a patient with a BXO, or in a patient with the posterior urethral valve, in a patient with a urethral stricture. So all these things, Uroflow PVR is a very useful test as a bedside test. The shape of the curve is also important. In addition to the Qmax, the shape of the curve, a bell-shaped curve, as I said, is normal. Then a tower-shaped curve is a feature of a high-pressure voiding. Then irregular curve can be staccato voiding due to detrusor sphincter dyskinesia. Then interrupted curve is a curve of hypotonic bladder. Then plateau curve is a curve of a lazy bladder. Then prolonged flat curve is something which suggests an obstruction. So if you look at all these curves, then there are different types of curves here. And if you see, this is a very flat curve. Okay, so that's a flat curve is suggestive of an obstruction. Here, this is a normal bell-shaped curve. And in a patient with a detrusor overactivity, you have a tower-shaped curve. The time to Qmax is very short. The Qmax is much more than the Q average. And the voided volume is usually small. So because of the urgency. Now, this is the kind of curve they get it in rat tail appearance in prostatic hyperplasia. This is an intermittent flow curve. Intermittent flow curve is a neurogenic bladder. This is a staccato curve. The difference between staccato and intermittent is in a staccato pattern, the interruption is because of the external sphincter contraction. So it doesn't reach the baseline. Whereas in a patient with the atonic bladder or where they have lost the capacity as in a late posterior urethral valve, the bladder contracts and then it cannot contract. Then there is an abdominal contraction, then like that. So it reaches the baseline. So the intermittent flow is a feature of an atonic bladder. And this is a urethral stricture or PUV or post-hypospadia stricture where the curve is very flat. So when you combine it with the electromyogram, you get a lot of useful information. And as I said here, again, there is a small artifact here. So when we make it like this, then you get them Qmax here. And this is the electromyogram activity. Ideally, you should have a relaxation at this point. So there are, we have looked at the combination of Uroflow and electromyography in children. So we described 3 types of abnormalities. Dysfunctional voiding is a prolonged staccato curve with active pelvic floor and a normal voided volume. Detrusor overactivity is a shortened race, quiet pelvic floor and reduced voided volume. Detrusor underutilization is a prolonged flat curve, quiet pelvic floor and a large voided volume. So when we looked at it, these are the curve patterns. So this is a normal curve, that's a relaxation. This is a patient with a lot of contractions. Detrusor swings are dyskinesia. And this is a patient with an overactive bladder. It's a tower-shaped curve, high Qmax. And this is a patient where it's a prolonged pattern, large voided volumes, and then detrusor underutilization. So a combination of this Uroflow and electromyography can actually help you plan the treatment. So in a child with the lower urinary tract dysfunction, after a detailed history, bladder diary, urine culture, and ultrasound, if there is a hydroureteronephrosis or bladder wall thickening, we go for urodynamic. If it is not there, we confine ourselves to Uroflow EMG because we don't suspect a huge amount of bladder pathology here. So we are suspecting a voiding dysfunction in this patient. So we go for the Uroflow with the EMG. So if there is a patient with dysfunctional voiding or staccato voiding, then they need a biofeedback treatment of the constipation. If they have idiopathic detrusor overactivity, like an overactive bladder, then they need anticholinergics. If they have primary bladder neck dysfunction, then they need alpha blockers. If they have detrusor underutilization, then you have to do timed voiding, double voiding, and CAC. Now, overactive bladder index is something which we proposed recently, where we give a combination of various factors to this. So I will not go into the details because it's a really complex thing which is combining multiple factors. But essentially, it compares three things. So one is the Uroflow index, which is the average of a AV and Qmax. Other one is the time to Qmax, then the voided volume. So based on that, we can have something as a normal or a classical or equivocal. So we can decide whether the patient has got an overactive bladder based on this index. So let us stop discussion about Uroflow there and then go into urodynamic. So urodynamic study is an invasive test causing considerable distress in the child and has a risk of sepsis. So although the previous one is also a type of urodynamic, the Uroflow is also a type of urodynamics, that is more of a voiding study, whereas this is a cystometrogram. So the typical indications are neurogenic bladder dysfunctions like myelomeningocele, spina bifida, tethered cord, incontinence after pelvic surgery like a pull-through operation. It can be after an imperforate anus or Hirschsprung's disease or one of those. Then we have urinary outflow obstructions like posterior urethral valves or other outlet obstructions conditions which can be where the urodynamics can be beneficial. Then intractable bladder dysfunctions where the symptoms are very severe, upper tract changes are there. And when we do not perform urodynamics, this is more important, a simple bedwetting. There is no need for urodynamics. Classical voiding dysfunction, you have the history, bladder diary, we have done a Uroflow EMG, and then Uroflow has given you the answer, and then there is no upper tract change. You do not need a urodynamic study. Also, in a patient with a VOR, with no gallbladder dysfunction, they void normally, there is no bladder wall thickening, and there is no post-void residual or big problems, and your bladder contour looks normal on the VCUG. So we do not do a urodynamic study just because we have it. So the NITIS principle based on three important things. A study that does not duplicate the patient's symptom is not diagnostic. Then the second principle is failure to diagnose an abnormality does not rule out its existence. Then not all abnormalities detected are clinically significant. So these things, we have to keep it in mind, and then we have to interpret the urodynamic study with caution. So as I said, a video urodynamic study, the typical indication is when you have a patient with a VOR, but also has a diverticle. When that's a patient with a neurogenic bladder with a VOR and a diverticle. There you want to know whether the neurogenic bladder reporting is being neutralized by the leak or the pressures are vented upwards towards the kidney or vented downwards with the leak. In that such a situation, you need a video urodynamics, like a bladder neck incontinence, leakage via the stomas, or where UDS can be false normal. So these are the typical indications for video urodynamics. So when we come to the pressure flow studies, there are multiple phases there, filling phase and avoiding phase. So there are, this is how a standard the systometrogram looks like. So the principle of a urodynamic is what you need to understand. So what we are trying to measure is a detrusor pressure. So the detrusor pressure is vesical pressure minus rectal pressure. It doesn't have to be rectal pressure. For example, you have a colostomy stoma, you can put the rectal catheter through the stoma and then measure the intra-abdominal pressure. You have a gastrostomy stoma, you can put it through that and then measure the intra-abdominal pressure. Basically, you want to know whether the pressure which is documented in the bladder is because of the intra-abdominal pressure measured by any other method. So P det is basically P vesical minus P abdomen. That is the basic principle. So before a urodynamic study, it's important to have an informed consent. Parents should have a detailed description of the study and an explanatory leaflet. The urine culture should be negative. The bowel should be very well prepared. Otherwise, your rectal balloon is going to give a very wrong reading. I always prefer to get a natural uroflow and measure the post-void residual before starting, because at the end of the study, the children do not always void, so you cannot get a proper voiding phase study. One or more cycles of urodynamic study may be required, particularly in small children, because they just void without you giving a command. So that may be needed. Antibiotic cover is a must, and child-friendly environment is very much preferable. Now, some of the technical differences between children and adults. Adults, I mean, we can also say that adults, children more than 5 years are adults and non-neurological. And I put children less than 5 years and neurologically impaired children here. Neurologically impaired children, I mean, children who are like in a wheelchair. They are wheelchair bound. So here, they may not be able to do a sitting position sometimes by being a child. The leak cannot be recorded. Now, in an adult, you can put them in a sitting position and put the beaker, the Uroflow beaker below it, and then you can measure the leak. But in a smaller child, you have to watch for the leak. Then the fill rate is too low. Here, the fill rate can be normal. They cannot tell you the sensation. They will simply start crying in a little child. So that is a problem. And older children and adults can void at will. Here they cannot do that. Uroflow is almost always not possible at the end of the study. And because, as I said, systometrogram has got a filling phase and a voiding phase. But this voiding phase is almost impossible in little babies. So crying and distress can be a nuisance, younger they are, and in an older children and adults, they are cooperative. So bladder capacity, the principle, Coff's formula, age plus 2 times 30 is the bladder volume. This is a very important thing. It is an exam question. You need to know what is the bladder capacity. Age plus 1 times 30 is also widely used across the world. So that is also accepted formula. Then in a child who is less than 1 year old, you have to multiply by 7.5. So if the child is like 8 kilos, then it is 8 times 7.5. So, you know what is the volume like, it's around 60 ml. So something like that. So you need to know that. Now the fill rate is basically depending upon the volume. So you need to work out the volume and you want to fill the entire volume over a period of 20 minutes. Now let me give you an example here. We have a 4-year-old boy. So the bladder capacity is roughly like 4 plus 2 times 30 is 180 ml. And you want to fill it over a period of 20 minutes. So you have to fill at 9 ml per minute or 10 ml per minute. But you can't fill at 20 ml per minute like an adult. In an adult, it's usually 20 ml per minute. But in a child, it is usually 10. In a smaller child, it's even 5 ml per minute or less. and the slower fill in thickened bladders. Most of the time, we see children who are neurogenic with impaired compliance. So we tend to fill smaller volumes. So when you can actually do a rapid fill in certain children with incontinence and VOR, but we really don't practice that. So supine position, calibration is the most important thing. Rectal line is important. Rectum must be empty to get a proper rectal reading. EMG electrodes, I always prefer to have the EMG electrodes because it gives you the practice of interpreting the EMG electrodes. Then standard abdomen lines may be too large. They can cause a lot of distress, interfere with voiding, and voiding phase, as I said, may be impossible. So this is a standard urodynamic line, which is basically a abdomen catheter. One is for filling, the other one is for measuring the vesical pressure. And this is the standard rectal line, where it is usually attached to a syringe so that you can inflate and deflate this balloon. Now, this is a custom-made rectal balloon, and this is a 2 feeding tubes we are using instead of a abdomen catheter. So these are all possible in older children, where this each line, rectal line and urodynamic abdomen line, these are all expensive. They're like 2,000, 3,000 together. They may become like 4,000. Whereas here, if you do custom-made lines, these are much less. But this 2 tubes putting via the urethra is usually not possible in smaller children. And the problem with this rectal line is sometimes air bubbles and adjustment of these things are very difficult in this particular the custom-made catheters. Getting the child quiet can be a challenge in the past, but nowadays it is so damn easy with the advent of the smartphones. So that is not a challenge anymore. Is there a video there? I don't know. Anyway. So this child, they cannot be hanging to the toilet for life. So they should have a proper foot rest, proper back rest. So both are important for them to be comfortable and then sitting relaxed. This is an older child, cooperative child. So we have got a beaker here to record the leak. Whereas in a child who is lying down, you have to watch. Now, starting the urodynamic study, setting zeros, zero pressure is the surrounding atmospheric pressure. So calibration of the transducers and establishing the reference level is very important. The reference level is the superior edge of the pubic symphysis. When you start the study, you open the transducer to the atmosphere, set zeros, and then change the three-way stopcock to the patient. So when you do that, you have what is called a resting pressure. So the initial resting pressure inside the bladder is usually 10 to 20 centimeters of water if it is a supine, or 0 to 6 of water of detrusor. So you have to have some kind of pressure there. So the resting values are not 0. So basically you have typically like, P vesicle around 10, then P abdomen is around here 10. So when you subtract it, you get a P det of 1. So that is very important. Then cough every 1 minute, if every activity can produce a sharp deflection. So when you have that, you should have a subtraction, which means in a good calibrated study, there will be a cough impulse in both the vesical line and rectal line, but not in the detrusor line. Then slow fill, less than 10 ml per minute, and then faster the fill, all those things. I already told you all that. Now, you cannot set zeros blindly. As I said, it's important to have, after you set 0 to the atmosphere, when you open it to the patient, you should have some number here. So it is 12 minus 10, 2. That is okay. But a 0 minus 0 is not 0, because the 0 you thought as 0 was never a 0. Now let us see a video of a classical child with posterior urethral valve. So this patient has undergone a valve fulguration, and we have also done a repeat voiding cystourethrogram to ensure that the valve is actually gone. So this patient does not have any obstructive uropathy, and we know that, and there is no reflex. So the urodynamics is being done at the age of 1.5 years, and that is the urodynamic catheter, WMN catheter, and then the age formula is written in the urodynamic chamber. So basically, what we have to do is we have to catheterize, and then we have put the lines also, the rectal lines. So this is the transducer. So this is the rectal line is connected to the bulb there. That is the mother trying to pacify the child. And you can see, as I told you, there is a resting pressure in the bladder as well as the rectum. And then there's a slow fill we are doing. We have got the Uroflow EMG also in this patient. So this patient has started running here. So when we see that the pediatric, what has happened is right at the beginning of the study, the child started crying and voiding and a lot of unstable contractions or whatever, and then the child voided. So when the child voids, you can see a rapid increase in the detrusor pressure, or it may be a contraction. So you have to watch. This child is lying down. So you want to know whether it is a contraction or a void. A void is quite a high pressure, and a contraction is something which is there at the beginning or part of the study. So here the child had a contraction, and then started voiding. So this is a big pressure. This is the void, and then this study is being done in the radiologist suite. So we knew that the child has voided, and because the child voided pretty quickly, we can do a second run. In a small baby, we can do a second run. So we filled it again. So after voiding, probably this child is now quiet. He doesn't have a huge smartphone or anything. It's just a glow balloon. And the mother is doing a great job diverting the child, and then the child is not straining or struggling. So it is possible to do urodynamics. And then once the voiding is over, pressures are all pretty stable during the second run here. So we are actually watching everything. It's important to be in the chamber, urodynamic chamber, while the study is being done. So this child, although initial run had a little bit of fallacious reading, the second run started very well, and the pdet was very low at 5. And as we started filling higher and higher, so you can start some contractions appearing. Why I'm saying contractions is because these contractions are smooth waves, whereas cough reflex is a sharp wave. So you should know how to resist a cough or the talking, and this is probably a contraction. So some contractions are happening there, here and there, and so we feel more, the child will start voiding. So at that point, we need to see what happens, and then the pressure goes all the way up to 200. So during the voiding, it's okay for the pressures to go up. It actually should go up during the voiding. But during the filling, it is not supposed to go up, or it should pretty much remain stable. So this patient doesn't have reflux, and he had doesn't have reflux and no leak. And this is the initial set of voiding. Is the initial set of fallacious readings, and then you always get a printout and then study, because that gives you a better idea. So here some unstable contractions are there, and that is the voiding there. But pretty much it is compliant, and this is, I would say that for a well-blooded child, this is okay. Now, is this a different patient? So this is another urodynamic run. Here, as I said, it is a 15 and 14 and 1. It is not 0, 0, and 0. So there are some resting pressures there at the beginning of the study, and this is how it is progressing. Now, this patient, yeah, this is a different patient, yes. This is a patient with a neurogenic bladder. This patient is also in a lying position. So this is our old machine. This is the Labori machine. Labori is a pretty good brand to have. So we have the volume of filling here, and then the volume filling is coming here. It's around some 25 ml, 30 ml, and this is again being done in the radiology suite where the CM is screening is possible. So we wanted to contrast to that agent. So if you are able to move your urodynamic machine to the radiology department, you can actually get a video urodynamic study, and then you don't have to spend extra for that. So here you can see there is an increase in pressure in the intravesical pressure. So you can see that the calibration is from 0 to here, 0 to 100. So the pressures have gone almost up to 50 here. Then this is around 60. P detrusor is going up to 50, 60. So any P det more than 25 is bad, and any P det more than 40 is very bad. So this patient is also having a reflux. You can see that the reflux is happening at the half fill, and then so around 100 ml fill itself, there's a lot of reflux is going on, and the pressure also went up. But after the reflux has started happening, the pressure fell down. So we really do not know what is the real complaints here. And then as the pressure went up, either the patient leaks or if the patient refluxes, then it becomes a problem. And then video aerodynamics tell you what is the actual functional capacity of this patient. But always get a printout at the end, because the printout at the end will give you a very good summary of the interpretation of what you saw, because this is the online presence, whereas when you get a printout, you get an overall picture. Now, there may be sudden increase or decrease in pressures because of movement or blockage or rapid fill or catheter slipping into the bladder neck or impaired various things. So I will not go into all this little troubleshooting, but you should know that, a cough is a rapid rise in wave, whereas a contraction is a smooth rise in wave. When there is a change in the vesicle and in the detrusor, then you have a contraction, and that is not seen on the abdomen. When you have a rise in pressure in both vesicle and abdomen, then you know that it is a cough. When you have no rise in vesical pressure, when you have a rise in rectal pressure, and then a negative curve here, that is a rectal contraction. So you should be able to tell a sharp wave is different, a smooth wave is different, and what is rectal and what is vesical. So multiple things you measure during a urodynamic study. Bladder capacity, functional bladder capacity is something you can measure when the leak starts. End filling pressure should be usually less than 40. You can tell whether the detrusor overactivity, unstable contractions are there. Unstable contractions are the waves. They are nowadays called detrusor overactivity or neurogenic detrusor overactivity. So this is the new terminology for the old term unstable contraction. Then you also look at the compliance. Compliance is a derived value. Compliance is not there. So you have to work out the compliance. It is a change in pressure by change in volume. So bladder compliance is a volume required for a unit rise of pressure. I'll give you a simple example. As an adult, you are filling 400 ml of urine, and the pressure should not rise above 10. So your compliance is change in volume by change in pressure, 400 by 10, 40. So 40 is the normal compliance. So anything more than 30 ml is okay, normal compliance. As it decreases, it means the bladder is becoming thick and thick. A compliance is different from the end filling pressure or safe detrusor pressure, because pressure is a pressure. A compliance is a different thing. It's basically a compliance is change in pressure for change in volume. Leak point pressure is another measure which we need to know. So as I said, compliance is a derived value, and a steeper the slope, lower the compliance. For example, you have a steep slope, you have a poor compliance. The normal compliance, as I said, 300 ml fill, only 10 cc rise in pressure. Poor compliance, like you have a 300 ml fill, but pressure went up beyond 30, 40. So the compliance becomes less than 10. So less than 10 is a very poor compliance. Some typical examples, this is a normal urodynamic study. So throughout the study, the the vesical pressure has been stable, the detrusor has been stable, and towards the end, the patient voided also. The voiding station. So this is a typical example of bladder instability, detrusor hyperreflexia, or neurogenic detrusor overactivity. You should look for leak at each point here. Instability and non-compliance. So here there is a contraction as well as a rapid increase in the slope. So that is a instability. So this is a poor compliance. It's a poor compliant bladder. The pediatric goes very fast. And then after an augmentation and interferon of this one has become better. Now this is the voiding phase. Voiding phase is very rare in younger children. But in an older child, it is possible to get a voiding phase, which means while the catheters are in place, you record the P det as well as the flow. So what you measure during the maximal flow is called a P det Q max. So this is usually above 50, usually in the range of 50, 60 to 100. And in a patient who is atonic or not able to generate enough pressures, you can see the flow is very bad. But the flow is very bad not because of an obstruction, but because the patient is not able to develop a detrusor contraction. You can see that his vesicle is the abdomen is contracting. So any change in the vesical pressure is because of the abdominal straining. So each straining is reflected in both abdominal and vesicle, but there is no detrusor pressure. This is a typical example of a atonic bladder. And there are a couple of indices. Bladder contractility index. This is typically used and bladder outlet obstruction index. So they are used in patients with the BPH and poor uroflow where there is a cause of poor Qmax. It has to be differentiated whether the poor flow is because of the weak bladder or an obstruction. But this is very much applicable in late posterior urethral valve where it can be used. For example, this bladder contractility index is a combination of P det at Qmax and phi Qmax. So when the contractility is good, you can have this, whereas in a patient with the late posterior urethral valve, this is poor. This is another index called bladder outlet obstruction index. So this is P det Qmax minus 2 Qmax. So this is again, although it is developed for posterior urethral valve, in a patient with a stricture, this will be abnormal. Now, one more thing you need to be aware of is detrusor leak point pressure and abdominal leak point pressure. They're typically used in an adult with incontinence to differentiate the cause of the leak. So the detrusor leak point pressure is basically the bladder contraction causes the leak, whereas abdominal leak point pressure, or also known as valsalva leak point pressure, is where a straining or cough causes leak. So that is usually a marker of a stress incontinence or a weak sphincter. So DLPP is a surrogate for outlet resistance. More than 40 means renal damage. So poor compliance with high detrusor leak point pressure, there's a high chance of kidney damage. So this is something which you need to be aware of. Then abdominal leak point pressure is a surrogate for internal sphincter deficiency or stress incontinence, and you can use it to decide various procedures accordingly. Now, how to interpret and create a urodynamic report is important. During the storage phase, you need to look at detrusor activity, whether the detrusor is normal or stable, overactive or unstable contractions are present. Then bladder sensation, whether the patient is able to tell the sensations, first sensation, second sensation, whether the bladder capacity is normal, high or low. Then whether the bladder compliance is normal, impaired or poor. Then you should also tell about the urethral function during the storage, whether the urethral closure is normal or whether the patient has been leaking throughout. Then in an avoiding phase, you again have to tell about the bladder function, whether the bladder is normal or underactive or acontractile or areflexic, or whether the sphincter is active, like a detrusor sphincter dysenergized there during the voiding. So you always have to get a printout, and you should always have an idea about what is here between 0 to 100. Sometimes you get a 0 to 50, in which case the appearance will be totally different. Whereas if you have 0 to 300, then the curve will look quite normal, although it is actually not normal. So you need to know what is the length and width of the curves, so you can easily alter it. So in a neuropathic bladder, you can have a multiple combination of a an overactive sphincter or overactive bladder, underactive sphincter, underactive bladder, and combination of these abnormalities, and having a voiding cystourethrogram. Before the study is what we do these days, because we do not have the luxury to have a video urodynamic setup. So typically I get a VCUG before the study. So in a neurogenic bladder, the primary aim is to safeguard the renal function, minimize the risk of UTIs, ensure that the urine is stored at low pressures, and the bladder empties completely every 3 to 4 hours. And then the other aim is also to socially acceptable degree of urinary continence. So the steps to promote safe storage are increasing dose of anticholinergics, then add another anticholinergics, or try intravesical anticholinergic. Then if the refractory cases, try botulinum toxin. And then if it is still refractory, you can repeat Botox injections or augmentation cystoplasty. So the idea of your augmentation is to make the bladder safe. For example, a 25 centimeter of water is bad for the patient, 50 is even bad. So you tend to change the slope of the curve by doing an augment or anticholinergics, and you ask them to do a CAC by the time it crosses the danger mark. So by doing augment, you reduce the slope, and by doing the CAC, you empty the bladder, then you protect the upper tracts. So this is the typical patient who underwent a bladder augmentation and Mitrofanov. You can see how bad these urodynamic studies were, and then now it has become very stable. In posturethral valve, even after the valve is resected, thick valve bladder causes raised pressures. The urodynamic screening should start from the age 5. And there are 3 different types of urodynamic patterns: overactive bladder, small capacity or non-compliant bladder, or myogenic failure. Okay.
Okay,
So 3 different types of urodynamic patterns are there: overactive bladder, small capacity non-compliant bladder, then myogenic failure. So what you have to do, you have to see what stage you are dealing with it. So it's a vicious cycle valve bladder. So you exclude stricture and residual valve, add anticholinergics, then timed voiding, double voiding, CAC, nighttime drainage, and then maybe a Mitrophone of an augment. And this is the typical progression of the valve bladder. So valve bladder with a simple nighttime drainage. This is a typical patient where the curve has become normal. The urodynamic curve has become normal by simple nighttime drainage. So in vesicouretic reflux, as I told already, we do not routinely recommend UDS in all children. It's a select group of children with dysfunctional voiding symptoms. Uroflow is often abnormal in other children, and MCU often have abnormal bladder contour, and these are the typical indications. And when we do video urodynamics, is large diverticulum, patient has gross VOR, and patient leaks throughout. This is a patient with a complete sacral and it is funnel-shaped bladder neck is incontinent, urine is going up. So you're going to get a normal urodynamic study in this patient, even though the bladder looks very small capacity. Then I don't have time to talk about this natural fill cystometry and all. So these are all fancy things: ambulatory urodynamic recorders connected to the notebook, intravesical pressure via suprapubic catheters. So all these things are there. Then Bluetooth enabled ambulatory urodynamics, ultrasound-based and non-invasive UDS, biofeedback. Biofeedback, the main objective is to unlearn the bad habits of straining and contracting the pelvic muscles. There are 2 types of biofeedback: EMG biofeedback, then Uroflow biofeedback. So basically, the child relaxes the sphincter, external sphincter, and then the fish opens the mouth and then catches the jellyfish. The child can decide, if she has to catch more jellyfish, then she has to relax the sphincter. Now, I'm going to ask someone to unmute and talk. So who is going to take this scenario, first scenario?
Sir, this is Supraja, sir.
Yeah. So this is a 9-year-old boy. He has undergone a decade repair, and this is a Uroflowmetry done very recently, 2-3 days ago. This patient has come for a follow-up. Now, can you comment on this curve pattern?
Sir, the slope is not. One second.
This is a, let me remind you, forget about this because this is a volume. This is the
Yes, sir.
Uroflow curve. This is the Uroflow curve. Normally, you should have a bell-shaped Uroflow curve.
Yes, sir. But this is
What
a
do you
little
think?
flat, sir.
This is
It's a
flat.
flat
Okay.
curve, sir.
And what is the normal Uroflow in a boy? What is the Qmax?
Sir,
Maximal flow.
less 20
No,
ml per second,
anything about 10 is also
about
okay.
10.
But
Yes,
here the maximal flow is around 5.
yes, sir.
Okay.
It's a
Then,
flat curve,
so
sir.
it's a flat curve.
Oh,
Uroflow is impaired. Then what
yes.
else you see? Yeah, apart from this, what else information you want to know from this numbers? There are some
So
numbers here.
the PVR, sir, which is quite high, 76 ml.
So voided volume is something which you need to see. The patient actually voided a good volume.
Yes, sir.
So a PVR should be less than 10% of the voided volume. So
Yes,
up
sir.
to 25, 30
20
ml is acceptable, but he has got a large PVR. So what is your conclusion about this patient?
Sir, uh, curves. Sir, I mean, the obstruction is probably causing outflow obstruction is there, sir, which is causing it's high and the volume PVR is high.
So basically, we need
So
to put the structure. So we can do an AUG, we can do a PVR, we can look at the bladder wall thickness, whether we can ask whether he is getting UTIs, hydrourethronephrosis. If it is a short segment, we can do dilatations or optical internal ureterotomies. But if it's a long segment, then we have to go for one of those revision procedures. All right. Now we'll go to the second scenario. Are you going to tell or anybody else is going to tell? Is there? They can tell or you can tell whatever.
I'll tell, sir. This is Evangeline.
Anyone else? Yeah. Evangeline, tell me. So this is a uroflowmetry of a 6-year-old girl with urgency and frequency and wetting. So clinical
sir.
symptom, what does it suggest?
Detrus are overactivity, sir.
Yeah. And does your finding corroborate with that?
There is a high peak which comes down immediately, sir, which is seen in the flow curve.
So this is
With
an
a, with a
important
high
finding.
Q, with
Although
a high
it,
Qmax.
it's a, exactly. So this is a high Qmax. The Qmax is 20, whereas the average Q average is much less, is 2
Yes,
ml
sir.
only. So this is very high Qmax. And also the time to Qmax, if you know what that is, it's very short.
Yes.
This is a typical
Yes,
tower
sir.
shape because they are not able to hold. So a lot of
Yes, sir.
urgency is there.
Yes, sir.
Okay. The patient does not have a residual volume. So voided volume is a little, I don't know, what is the expected voided, bladder capacity on a 6-year-old girl?
It'll be a 6 plus 1, sir,
Okay.
7. 7 into 30. 200
plus. So
Yes.
the patient voided around 100 ml. So half the capacity only they can hold and then still produced a lot of pressure. Now I told you about the Sirocchi nomogram, right? So the nomogram is
Yes.
basically for the voided volume. For
Yes,
the
sir.
voided volume, this Uroflow is way above that nomogram. It's way above the normal range. So this is suggestive of what?
That there is a reflexor that is accommodating the extra.
No. Urgency frequency wetting, what you said is correct, and this is fitting with the diagnosis, which
Yes,
is
sir.
overactive bladder.
Detrus are overactive. Yes, sir.
Yeah. So what is the treatment?
One is first biofeedback and training the child itself, maintaining avoiding diaries, sir. Then we have to relax the bladder by giving anticholinergics. Bowel bladder management also has to be instituted in case the child has an accompanying constipation.
Is the word used for a combination of fluid intake, bladder diary, timed word, and diet. And then we can try medications like anticholinergic, beta agonists. Then we can even go for a TENS therapy. A TENS therapy is basically you apply symmetric biphasic current at a frequency of 100 hertz, pulse width of 400 microseconds for 20 minutes. This is one of the patients which we are giving TENS treatment here for an overactive bladder. And this was done, this photo was taken around some 5 days ago. So this is repeated on alternate days for 2 to 4 weeks. This is as good as the anticholinergics without the side effects of the anticholinergic medication. Now, the third scenario, anyone else wants to answer this, or we can go back to either Evangeline or Supraja? Anyone else?
Good evening, sir.
Yeah,
So
this is an
Suren here.
8-year-old girl with the wetting and constipation. Now, tell me from the history itself, what do you think?
Sir, it's the interrupted cursor. So must be a bladder ball dysfunction looking like because of sir, it's a neurogenic bladder, I think.
No. It's not an interrupted curve. It's a staccato curve. Because a staccato curve does not reach the baseline. Okay?
Okay, sir.
So an interrupted curve reaches the baseline, which is a atonic bladder. This is a staccato. Staccato wording, what does it refer to?
Sir, this
Yeah, for your diagnosis only, I put some picture here. What does it look like?
sir, it's a
What is the typical picture of this? This is a picture of what? This looks like something which we play during childhood. This something which we play during childhood, you know?
sir, a spinning top.
Exactly. It's a spinning top urethra because of what? Why do you get that appearance?
Sir, posterior wall.
No. Posturethral valve is not spinning top urethra. This is a girl child. So it's typically a girl child.
Yes.
So spinning top urethra, wetting, constipation, staccato voiding. So what do you suspect? Why is it all happening?
Sir, dyssynergia or
Correct. So detrusor sphincter dyssynergia is the term. So basically the treatment plan here is to treat the constipation, relax the sphincter, diet warding thing. So this is where the biofeedback comes. So biofeedback is basically you show them either this or this and then ask them to relax. So you do the biofeedback basically to unlearn the bad warding habits. Then you can even try a Botox internal sphincter or external sphincter Botox. Now, anyone else wants to tell about this patient? 14-year-old boy. He had a PUV fulguration at birth, hydrourethronephrosis, wetting, raising creatinine. Who else is there? Siddharth? Is there? Anyone else is there? Somebody
I can answer if
Nobody
no
can
one
answer.
else is.
Yeah. So it's a 14-year-old boy, valve fulguration done at birth. He has got increasing hydrourethronephrosis, wetting, raising creatinine. So from the history itself, what do you think is happening?
A valve bladder syndrome is setting in.
It is a valve bladder. And what stage of valve bladder is this?
Looking at the curve, sir.
If you look at the Uroflow pattern,
yes, sir,
yeah,
that
what
looks
does it
like
look
an
like?
intermittent flow curve, it looks like, sir.
This is a
Because
typical
it's-
interrupted pattern compared to the previous one. That is a staccato. This is
Yes,
interrupted. Okay.
because it's
It
touching
goes
the
all the
baseline.
way. Then what do you comment on the volume voided?
The volume voided is 736, sir, which is very high for
A
his age.
huge volume. So it's
Yes,
become
sir.
an atonic bladder, and this is actually given up. So this is a late valve bladder, and he is the patient who typically needs a what treatment? Timed
He
voiding,
needs an yes, sir,
double
CIC.
voiding. Yeah, so nighttime drainage is the first thing we'll start. Then CAC, Mitrofanov, button vesicostomy, and there is limited role for medicines anymore. So basically, he needs CAC. Okay. Now
Sir,
this is,
have
I
a
think,
doubt,
last
sir.
scenario. Yeah, please tell.
So that previous the second graph, sir. Yes, sir. The second graph is the no, the one after this. The PUV boy with
This
the
is the
valve.
flow.
Yes, sir.
This is the
Oh, that
flow.
is the
Volume.
okay. The red is also flow.
Volume.
Okay.
This is the
Okay,
flow.
sir.
This is the volume.
Okay, sir.
So you get in a Uroflowmetry, you get only this. This is a voiding study. This is not a urodynamic study.
Okay,
So don't
sir.
get
That was
confused.
Yes, sir.
Okay.
Yes.
So,
Okay,
so
sir.
urodynamic study, Uroflow can come in different types. This is one type of Uroflow curve printout. This is another type of Uroflow curve. So when you
Okay,
have
sir.
a only outpatient Uroflow machine, where
Yes,
it's
sir.
not attached to the Uroflowmetry, the Uroflowmetry is a separate machine. It gives a curve like this. If the
Ah,
Uroflowmetry is done in a urodynamic machine, it gives a curve like this because
okay,
it's
sir.
combining both.
Both. Yes, sir.
It's giving a
Understood,
flow
sir.
also.
Yes.
This one did not give a flow, the volume voided.
Yes,
It is only
yes,
measured, but it not did a curve. Here the
yes.
curve is also given. This is not a urodynamic, and this is a urodynamic curve where you have P vesicle, P abdomen, and P detrusor, and this patient has got a outgoing urodynamics, poor compliance. So this is what I want to stress about the reporting. It's a known case of myelomeningocele. So in the reporting, we are given everything. Pre-study Uroflowmetry not done. Then MCU shows all these findings. So urethra was normal, irregular bladder counter, no VUR. And then sitting position, stable bladder, fill rate, filled volume, no unstable contractions, no leak. Then first sensation, first desire, strong desire. We have mentioned all that. Then we went into the various no unstable contractions during voiding, no abdominal straining during voiding, voided last, then post-void residual, how much is that? So the impression is small capacity bladder. Expected bladder capacity is 390, filled up to high pressure bladder without any uninhibited contractions. So the pressures went up, the P det went up, but there was no other contraction significant. So continue anticholinergics, bladder diaries, CAC to be continued. If that doesn't get better, then bladder augmentation. So this is the complete urodynamic report, what you need to give for this patient. So this patient probably needs anticholinergics, beta agonist, urethral CAC, bowel management, then Botox into the detrusor, reflux for the vesicular reflux maybe, then lap mitrophanoff, lap mace, bladder augmentation, mitrophanoff, all whatnot will be needed in this patient later on. Okay, so I will stop it at this point, and then if there are any questions, I will answer. Questions on the chat box or any doubts or anywhere about the urodynamic study?
Sir, one person had asked initially itself, sir, what is the site for your surface electrode placement?
EMG, right?
Yes, sir.
So the EMG electrodes are placed on either side of the anal orifice. Basically, the EMG electrodes pick up the external sphincter. It is not for the internal sphincter.
Yes.
Okay. The questions, we'll close this session. I mean, urodynamics is a little complicated and extensive subject. I suggest that you guys read about it, all of it. Yeah, can I use 2 feeding tubes for children, right? Yes, I mean anybody more than 7-year-old you can do that, but in rest of them it is not possible. So you need to have a certain age for this. Smaller children it is difficult. Okay, any other question?
Someone else has also asked, sir, is the study accurate if we do under GA? But I think if we do under GA, the pressures and the flow won't become.
See, it's a bit like MCU. A lot of parents ask, can we do the MCU under GA? It's not correct to do it under GA. MCU needs a voiding child and then a awake child. Similarly, urodynamic study, you need to know whether the child is active, crying, cough reflex, subtraction is there. All that you need to know. So if you have a relaxed child, then there is no point in doing the study. Is it right to say that compliance is generally low in infants owing to their physiological low capacity? Well, in infants, doing urodynamic study is a real pain. There are multiple schools of thoughts. In neurogenic bladder itself, we do not do the urodynamic study in less than 2-3 years old, because when we do the bladder ultrasound itself, we are able to tell about the bladder wall thickness, bladder postward residual, and in the voiding cystourethrogram, we are able to see that the bladder counter is not bad. So most of the time in neurogenic bladder and post-urethral children, we are able to delay the urodynamic study until they are like 4 or 5 years old. So we don't do it as soon as they are little young. Somebody has asked, do we have to stop propan to assess urodynamics or in any condition? Often we get children who is already on anticholinergics. The idea is whether we are able to have, you can see whether your anticholinergic is working. So if the urodynamic study is poor, even while on anticholinergics, you either know that the anticholinergic dose has to be increased, or you have to go for some other method like Botox or augment. So although we say that we stop anticholinergics, having them on anticholinergics is not a thing. And if you have a normal study on anticholinergics, then you know that anticholinergic is working. So you can say that urodynamic with an anticholinergic is just has to be reported that this child is on anticholinergic, and this is the finding while on anticholinergic, right? Now, do we have a role of UDS in post-bladder augmentation? Yeah, I mean, after bladder augmentation, the urodynamic study invariably will be normal, because when we do augment, we tend to oversize the bladder. We tend to increase the capacity beyond certain limit. That's invariably normal. So when you do a urodynamic study after an augment, now these days people do robotic augments. So when you do robotic augments, you are little afraid to make a huge augment, so you make a partial augment, or you don't bivalve the bladder as much. So in such a situation, your augment is small. So the Mitrofanov is leaking, or there's a urethral leaking incontinence. And after augmentation, you do not know whether the leaking is because of the bladder neck problem, or the Mitrofanov incontinence, or the bladder contraction itself, which has become manifested because of a small augment, whether you have to add an augment. So in such a situation, you need urodynamic. But if everything is going well, I really don't think you need an augment. Okay. Now, if reflux happens during urodynamic study, till what point can we continue the study? Now, how do you know that reflux is happening? Unless you have a video urodynamics, you won't know, right? So there are many patients where we think that everything is honky-dory, but the entire kidney is being filled up by you. So if you don't have urodynamics, then you probably have to do a video. If you don't have video urodynamics, you have to do an MCU. Then when in the report you say that this patient has grade 5 vesicular reflux, so my urodynamic diary being normal should be taken with a pinch of salt. So that you have to report. Now, if you have a video urodynamics, then you have a reflux happening, then, if the pressure is going up, and then you know that the entire thing is filling in, filling the upper tract, or right after the pressure goes up, it fills the upper tract, there is no point in continuing the study, you can stop it. So there's no point in continuing to fill the upper tract and then damage it in front of your eyes. Okay. So yeah, more questions are coming. Based on UDS, if a child is on anticholinergics, when to repeat UDS to check for improvement? Now here, there are a lot of other ways to check somebody's improvement. So doing a urodynamic study, again, I keep on repeating this, presence of a urodynamic machine is not an indication for urodynamic study. It's quite an invasive study. It's quite traumatic, and it can really cause urosepsis and hematuria, false passage, all whatnot. So you can assess the bladder diary, frequency, wetting episodes, then whether the child is upper tract is getting better, if the renal function is deteriorating, whether that is getting better, whether the number of UTIs are improving. So many things you can assess. So simple ultrasound, all those things, if they are working, then you probably don't have to repeat the urodynamic study. So urodynamic study typically we do before an intervention. For example, I am planning an augmentation. I definitely need a urodynamic study. I am planning a renal transplantation. I need a urodynamic study because I can't put a kidney into a bad bladder. So like that. So those are the typical indications where you have to do. Then clinically deteriorating. Clinically, like the child is having multiple leaking episodes, incontinent again with medication, or the upper tract is going bad. Then I need a repeat urodynamic study. So a urodynamic study will be indicated definitely in certain situations, but not normally. All right. So if there are no more questions, thank you very much for joining.
Thank you so much, sir, for taking out your time for this class. I think we all
Very
really
much.
learned a lot. Yes, sir.